Hello, everyone. I'm Mark Plaster, and this is EP Talk, a place where EPs, emergency physicians, come to talk about anything that we want to talk about, personal, professional. And my guest today is Bill Sullivan, who everybody in the world knows for his acerbic wit and his willingness to take on the giants in medicine. And so I love talking to Bill. He's on our board of editorial board, and he's always the guy who has researched it and then usually sued somebody over it. And today I want to talk about. I think everybody knows that I think we've got a little bit of distance from COVID enough that we can start to talk about the what I call the damage that's been done to our profession by the arguments, the uncivil arguments that and the actions that have been taken about how we handle COVID. And First of all, Bill, thank you for agreeing to come on, and
Anytime.
it's always great to talk to you. Great to talk to you. I think we talked about before, and I think people have already seen about when you sued the Board of Medicine in Illinois dealing with. So give me 30 seconds of summarizing that, exactly what that suit was about and how it ended.
Well, so the suit was just about the Illinois board sent out a notice saying that if anyone prescribes ivermectin, if anyone gives people mask releases from having to use masks, or if anyone disseminates misinformation about COVID or anything else, that they were going to consider licensure action. And so what I did is I wrote to the Illinois board and I said, all right, you want to do these things? Fine. What's the basis for all of these actions? There's got to be some type of a scientific basis. What is it? Give me the information. And they didn't do it. So under the Freedom of Information Act in Illinois, you can sue to force them to do the information. So it's not like I'm suing the board for doing these things. I'm suing the board because if they're going to go after someone's property rights, their medical license, right, there's got to be a scientific basis for doing it. And the only reason I sued was because I wanted to get the scientific basis for it. So I filed a Freedom of Information Act lawsuit. They wouldn't give me the information for almost 9 months. And eventually they gave me what they had, which was a bunch of emails back and forth trying to create these things that they're going to potentially go after a physician's license for. They cited two statements from two other state medical boards,
and but no research. It wasn't based on research. It was based on other states' policies.
Right, other states' policies, but they had no scientific. They didn't give me one study at all. There's nothing. So, and that I thought was pretty telling. That they would say, "Hey, we want you to make scientifically based statements and avoid misinformation." But at the same time, there wasn't any scientific basis for the actions that they were threatening, and that was the issue I had. It wasn't that they were threatening these things to begin with. It's they don't have any scientific basis for it.
Right. And that's actually what I want to sort of talk about. I think that that the public is starting to kind of get the understanding that a lot of medical policy has not been based on real science. It's been based on very flimsy science at most, and sometimes, as you found out, not science at all. And
I think the medical profession is taking a big hit just in the eyes of the public because of that. And you think about when COVID first started, you had people that were out at 4 o'clock every afternoon banging pots and pans together and saying, thank God for doctors. And fast forward 3 years and nobody trusts medicine anymore. You see all these articles and you see comments to articles about how nobody trusts their doctors. And that's kind of sad.
Yeah, the hospital where I work had a big giant sign out in front, "Home of the Brave," because we were the ones willing to come in and take care of the patients. I worked in a COVID field hospital, and we did the whole spacesuit gizmo to take care of the patients and all that stuff. And so the kind of slobbering admiration you get from people during those time periods is just amazing. And just as you've said, we have now fallen from grace because of some of the things that, like what you're saying, people are saying, well, wait a second, did masks really do anything? And then when they finally come out and say, well, they didn't really do too much, maybe not really anything. And so all this browbeating and get your mask up over your face, get your mask up over your face, the flight attendant, coming back and threatening to throw you off the plane if it's not all the way over your nose and all that
Yeah.
kind of stuff. And that started to hurt. And I wanted to bring up something I've read about recently, and I'm sure you're familiar with because you're always up on the news. And it has to do with one of the competing publishing companies, Elsevier. And there was a study that looked at autopsies of deaths that occurred in the first, I forget the time window, it might have been a month, it might have been 2 weeks to a month, I forget what it was, post-vaccination. So they wanted to find out if there was a link between the vaccinations and sudden death. And sudden death, obviously, is something we in emergency medicine have a real vested interest in. And so,
Right.
so they put together the study. They came up with like 400 deaths out of a whole series of several hundred studies, and they then looked at the ones that were related to time sequence and such the vaccination, sent the autopsy reports out to 3 different adjudicators, and the adjudicators came back and said, yes, it was related to COVID vaccination. It was related to vaccines, or it wasn't related to vaccines. And unfortunately, they found that 75% of these sudden deaths that they were actually studying, and it was over 300, I think, were in their independent opinions. And they had people reviewing it who were like the heads of pathology societies. We're not talking about Joe Dokes, and they were saying yes, it was related to these are healthy people who died of cardiac embolism related to the vascular complications of COVID vaccine. Well, anyway, when this thing was put up on a preprint server, it wasn't going to be published for a couple of years. It was put up on a preprint server that the Lancet carries, and it was flying off the server at an extremely rapid pace. It got a lot of press right away. And guess what? Elsevier did. They took it down. They took it down. They took it down, and I think that I'm really concerned. This is, and now this study, this is now percolating through social media that a study showing a high correlation of sudden death and vaccination, and it is almost trying to breed a conspiracy theory that, if you think that that maybe certain people shouldn't be taking vaccines, the COVID vaccine.
So I think there's a few things. I wasn't actually, I don't know the study itself, but the idea that there's something inherently bad about journals taking down studies. There's actually a site, it's retractionwatch.com, that lists all the studies that have been retracted by journals. And in between 2017 and 2020, I think there were more than 8,000 studies that were retracted. Now, they weren't all in medical journals, but there were a total of 8,000 studies that were retracted. So with regard to COVID, there have been about 350 or 360 studies that have been retracted. So it may seem like, okay, there's a lot of studies being retracted about COVID, but overall, the sheer number of the studies being retracted isn't an outlier. Then you have to think about, okay, why are they retracting the studies?
Right.
And that's where there's a big problem. Like some of the journals will retract studies. Like I've read other studies have been retracted where they say that the authors didn't thoroughly vet the data that they had, and the authors wrote back and said, well, yes, we did, but they wouldn't put the study back up. So some of those people actually published their studies on Substack instead because they couldn't find an author to publish them. But then it goes back to, how does that affect the public perception of the medical field if there's something that maybe some people in medicine don't agree with? The author, or not the authors, but the publishers of these studies, of the magazines, don't agree with the conclusions of the studies. Instead of debating it, they just censor it. And I think that's something else that tends to lead to distrust of medicine, and it's unfortunate.
Yeah, the interesting thing about this particular study is that they actually, because it's electronic, you have the ability to almost, as we've discovered, to have unlimited information. So they published actually each one of the cases. You could actually look at the date. You could look at the findings for each one of the autopsies. And so, in essence, they sent it up to 3 adjudicators, but really they sent it out to hundreds of thousands of adjudicators who would actually look at the case materials themselves and say, yes, I think that this was a vaccine-related death, or no, it wasn't. It was almost like crowdsourcing. Okay, this is what we found, but we're also going to give you the raw data,
which is how it should be.
Yeah, we're going to give you the raw data, and you look at it and you say, you call bullshit on us if you want, if you think that the adjudicators, have looked at it with a jaundiced eye. And I think that's the problem. It was actually fairly put out. And
do you know off the top of your head what Elsevier said was the reason for them retracting the study?
Bad methodology. That was their faulty methodology.
Isn't it kind of weird that Pfizer and the CDC want 55 years to disclose all of the information related to studies actually showing that the vaccines work?
Yeah.
Kind of ironic, huh?
Yeah. It shifts over to something that I think is relevant clinically to our practice in emergency medicine. And that is that, I think everybody has seen or has talked to somebody who knows somebody who's had a sudden death in the post-vaccine window. And the most famous one, of course, is Damar Hamlin, the guy the professional football player, and that was explained away as just a timing thing. He got hit just at the right time to have to catch
cordis.
Yeah. And I felt like saying, do you know how many million hits there are in football? I mean, we should have a ton of those kinds of deaths if that's the case. Yeah. And that's not what actually happened.
Right.
And so I have wanted to ask my colleagues, and so I'm asking my colleagues now, are we getting CPK levels on young, healthy, particularly men, more likely to be males? Are we getting CPK levels of young people who've come into the ER for other reasons in the post-vaccine window to see if there is subclinical myocarditis or subclinical elevations of CPK levels in patients that we wouldn't otherwise see? Does that make sense to you? I mean, I think that I'm worried that there is a sea of myocarditis that's subclinical. People are getting mild amounts of chest pain and not doing anything about it. What do you think?
I think if you look at the studies, the New England Journal actually did a study on this, and I want to say that they came up with the incidence of about 30 cases of myocarditis per million patients. If you want to extrapolate, just do napkin extrapolation. You multiply that by 130 million emergency department visits in a year. You're talking about 4,000 cases of myocarditis, vaccine-related myocarditis. Now, is that enough to screen for? Yeah, you can argue one way or another. Are the data that the New England Journal came up with valid? You can argue that too. But the bottom line is, when you're talking about sudden death, it's kind of crazy to me that we've normalized sudden death, because a few years ago you never saw it. And
No,
we've normalized the concept of sudden death, but we've also made it that anyone who has sneezing and coughing is a pariah. You stay away from me. So it's kind of crazy. But there, even with the increased incidence of myocarditis, I don't think that screening for patients just in general is a good idea, but I have a really low threshold for doing CPKs and troponins on anyone with chest pain now, just because of this.
yeah.
So I don't know that we could say anybody that comes in needs to have a troponin level drawn just as a screening level, but someone that comes in with chest pain, unless it's the etiology of the pain is pretty clear to me, they're getting some type of cardiac enzyme and an EKG done.
Yeah. I guess I'm not really, I would be interested in the academics of knowing how many people in the post-vaccine period have elevated CPKs. Would that mean that they had actual myocarditis? Well, possibly. Would it mean it was dangerous to them? Probably not. We're not seeing, but I'm just curious about, I'm with you, and the people that come in with even funny chest pain, young people in the past who came in, I would assume it's pleurisy. I would look for pleurisy. I would look for costochondritis. I would look for esophagitis. I would look for all those other things. And I'm basically, in my brain, I'm saying this is not cardiac, okay? Unless they had a rub, unless they had something that would really kind of tip me off that this is cardiac. That's not true anymore. It's not true anymore. And I think that we do our patients a disservice by not moving that way up on the differential diagnosis. So I'm kind of curious.
I'm with you on that. I mean, unless someone comes in, they've got broken rib on an X-ray with a history of trauma, or they've got a rash, like looks like shingles, or sometimes if somebody's got localized pain, I'll actually do a little bit of a trigger point injection. If I can make the pain go away with that, then okay, I'm going to say it's not cardiac, but otherwise, gotta look into it a little bit further.
Yeah, and I know that my partners and colleagues would probably look at me kind of squirrely if I started doing CPK levels on teenagers, with chest pain. But I think that's probably appropriate now.
There's just an anecdote. I had a 16-year-old kid that got called in by ambulance as a stroke alert. And we're saying 16? They're like 16. They're like, not 60, no, 16. And we're like, okay, yeah, this will be good. He came in with complete hemiparesis on his right side, no, it was on his left side. And he ended up having a stroke. But when he got to as we were doing the workup to prepare to ship him out, we did a chest X-ray, and both his lungs were whited out. I'm like, what is going on? So he got to the stroke center. They were actually able to evaluate the clot, and he got most of his function back, but he ended up having a cardiomyopathy, and he needed a heart transplant.
Oh.
And he was post-vaccination. Now, I don't know, you can't say correlation is causation, but you just want, he was a 16-year-old kid.
Yeah. And
so you can't rule it out based on age anymore, just based on age.
Now, going back to the original hypothesis that we started out with, I know you and I are talking, do you feel comfortable with this conversation with other people, other clinicians, or would this discussion get us in trouble?
It'll probably raise some eyebrows in some people and saying, okay, all right, Sullivan and Plaster, where's your scientific basis for this? But some of it just, you go to heuristics. What's the likely cause? You have to look, if you can define a likely cause of someone's complaint, whether it's chest pain or anything else, then maybe you don't need to do as much testing. But if you're still not sure about the cause, at least you have to consider, is this some more even in a young person, is this a potentially deadly diagnosis, like a PE, or like some type of a heart issue?
Right. Yeah.
I don't think that you can discount. I agree with you. You can't discount it anymore just based on age. You have to look at other factors, and the fact that there's an increased incidence of myocarditis and of clotting after receiving vaccination is one of the other things you have to consider. Now, maybe you say, okay, I consider it. I don't think it's that's going to contribute to
Yeah.
the case at this point, given the patient's presenting symptoms, but at least it's something you gotta keep in the back of your mind.
Okay, now take this case, the 16-year-old who had the stroke. Okay, I want you to put your lawyer hat on now. Okay, put your lawyer hat on. And if that family came to you afterwards and said he was in the ER, 5 days ago, complaining of chest pain, and they did not evaluate him as a cardiac, as a potential for a cardiac embolism, or embolic disease. Do you think that we are exposing ourselves now that this information is starting to come forward? Are we exposing ourselves to liability by not having that in the differential diagnosis?
Seeing that, so remember, medical malpractice is duty, breach, causation, and damages.
Right.
But the breach of duty thing is what a reasonable doctor would do under the same or similar circumstances.
Right.
So it's a case-specific determination. So is it possible that there was malpractice in that case if he was in the ER 5 days before? It's possible, but it really depends on the presenting complaint and what the physician saw. It's also possible that there wasn't any malpractice. So I don't think you can paint it with that broad of a brush.
Well, I'm just saying, for instance, you and I both have seen and probably litigated PE cases that were brought against ER docs when the patient came in and had shortness of breath or some sort of a funny complaint, and the doc didn't do the full court press evaluation for pulmonary embolism. The patient dies, the suit comes back to the emergency physician. And I think you're absolutely correct. It's completely fact dependent and case specific. But I guess I'm trying to get my colleagues to start thinking, a little more cautiously about young people, particularly young males in the post-vaccination window, who have even remotely cardiovascular or coagulopathy kinds of issues that you may, if you're not thinking in that regard, you may in fact be exposing yourself to liability if bad things happen.
Yeah, I mean, nobody likes to see a bad outcome, and it's difficult to argue your case in front of a jury when you've got a sympathetic plaintiff who the 16-year-old had a stroke, for example. So that's tough. But is it the standard of care to do it? I don't think so yet, but it's just something to consider in your differential diagnosis. I think that's a fair assessment.
Yeah. Okay. I just wanted to bounce some ideas off of you in regards to this, because
you're trying to get me in trouble, and I'm not going to let you.
Well, I'm just seeing more. I'm more and more concerned about sudden death. Okay.
Right.
And I'm very concerned about sudden death and cases like you're talking about, young people with incredible morbidity. And it seems as though the politics of this particular condition has really either forcefully put our hands over our eyes or voluntarily put our hands over our eyes concerning the potential of the interaction between vaccine and coagulopathies and coagulopathic disorders. And so I just think that something has to get us thinking, to put the politics aside and start thinking in terms of risk. And as you say, maybe it's not as huge as I'm making it. I'm kind of hypersensitive to it because I saw this study, and I was just flabbergasted that Elsevier would take it down rather than let clinicians and epidemiologists and researchers just go to fight it out with the data. They took it down and tried to bury it, and I thought,
and you wonder now whether it's going to hit the Streisand effect thing, whereby by taking it down, they're going to cause more interest in it in terms of why did they take it down? What did it say? So
yeah,
who knows?
Yeah, exactly. With the Supreme Court decision that trying to constrain the Biden administration from influencing social media platforms. And the real question, I don't know if somebody's going to actually do it, but to freedom of information, that may be something that you might want to do.
Yeah.
is to
I got enough on my plate right now, brother. Thank you.
go after Lancet and say, can we see any emails that you've had from the FBI, the Department of HHS,
It's only the freedom of information is only for government entities. So Lancet can say,
but you can go after them and say, have you been, because you see, if in fact, now that would be pre-Supreme Court decision, so it wouldn't have been in violation there. But it would be interesting to know if they took it down under the influence of a government entity. That's my question. Yeah. And that's where the research and that's where the concern is going to be. So anyway, I just thought on this wonderful Wednesday afternoon, I'd pick your brain and see what you thought. To addressing our viewers, emergency physicians, researchers, epidemiologists, these are questions that we hopefully can come out of the woodwork with and ask openly and honestly. These are things we wrestle with at the EPM editorial board meetings oftentimes, and we would like to have your input for you to say, yeah, I think that's baloney. I think, Mark, you're overreacting, or no, I think this is something that is being swept under the rug to the detriment of our patients, and I think to the detriment of our reputations as being honest purveyors of medical information and what's really best for you as a patient. So anyway, we'd like to hear from you. We're just about out of time, so let us hear. This is thanks for joining me, Bill. And
anytime. We'll have to do it again soon.
Yeah, we will. We absolutely will. Take care. Take care, everyone.